The subcentral gyrus is related to the speech production, and the transverse temporal gyrus is related to hearing. The surface cortex of insular lobe includes the inferior frontal gyrus, the ventral part of the central lobe, the anterior part of the superior marginal gyrus, and the anterior middle part of the superior temporal gyrus. The main surci include stem part and the lateral part of the sylvial fissure, horizontal ramus, anterior ascending ramus, and the posterior ascending ramus of the sylvial fissure. Inferior segments of the pericentral, central, and postcentral surci, ascending ramus of the pericentral, central, and the postcentral surci, as well as the superior temporal sulcus. In case we perform a simulated surgery on the cadaver, resection of the pars triangularis can reveal the first short gyri. Further resection of pars orbicularis can reveal all three short gyri, and resection of the pars orbitalis can be exposed to the anterior limiting sulcus. Resection of the superior marginal gyrus can reveal the posterior insular point and the retroinsular region. Cutting the ventral part of central lobe can reveal the two long gyri of the insula. If you want to keep the ventral central lobe, you can also expose the long gyri of the insula as well as the posterior insular point from rostral to caudal after the three short gyri are removed. The frontal operculum is removed to the level of inferior frontal sulcus, which can reveal the superior limiting sulcus. The temporal operculum resection revealed the ventral part of the insula to the level of the inferior limiting sulcus. Observe the cross-section anatomy of cadaver brain specimen. The superior longitudinal fasciculus part 2 passes above the superior limiting sulcus. In this horizontal cross-section, you can see the part 3 of superior longitudinal fasciculus projecting to the inferior frontal gyrus on the out surface of the superior limiting sulcus. The deep side of the sulcus on the superior limiting sulcus is the internal capsule, and the deep side is the body of caudate nucleus. In the cross-section of the frontal operculum, from the lateral to medial, you can see the insular cortex, the extreme capsule, claustrum, external capsule, putamen, internal capsule, dorsal thalamus, as well as the caudate nucleus. In the cross-section of the sylvian fissure, from lateral to medial, you can see the insular cortex, the apex, extreme capsule, claustrum, external capsule, putamen, globus pallidus, internal capsule, thalamus, and the head of caudate nucleus. In the cross-section of inferior limiting sulcus from lateral to medial, you can see the transverse temporal gyrus, the Lyman insular, ventral striatum, internal capsule, as well as the thalamus. The protection of brain function is not only in the protection of cortex, but also in the protection of subcortical neural pathway. Therefore, we must have a clear understanding of white matter fiber dissection. This photo shows the classic white matter fiber dissection using Kling technology. The acute fasciculus, superior longitudinal fasciculus, part 2 and part 3 surround superior, inferior, and the posterior edge of the insula. Under the insular cortex are U-shaped fibers. In the layer is the external capsule, which consists of the uncinate fasciculus, inferior frontal occipital fasciculus, and the cross-jewel cortical fiber from rostral to caudal. The external capsule is also called the temporal stem at the level of inferior limiting circles. So on this photo, you can identify the corona radiator, putamen, I4, as well as the uncinate fasciculus. It also includes the anterior commissure and the optic radiation, which extends backward to the sagittal striatum. The deep surface of the lenticular nucleus is the internal capsule, which extends upward to the corona radiator and downward into the cerebral peduncle. So on this photo, you can identify the anterior commissure as well as the sagittal striatum. On this photo, you can see the corona radiator connect to the internal capsule. And on the surface is the globus pallidus, and beneath is anterior commissure, and the posterior part is optic radiation. So the classic dorsal language pathway include acute fasciculus, superior longitudinal fasciculus, part 2, part 3, and the temporal parietal portion, and also the frontal axon tract. The classic ventral pathway includes I4, uncinate fasciculus, as well as the inferior longitudinal fasciculus. Among them, the injury of the internal capsule can cause hemiplegia, while the injury of the acute fasciculus
findings in the initial physical exam. Cognitive tests showed mild anomia. CT scan indicated a heterogeneous low-density left insular mass, which was hypointense on T1 weighted sequence and hyperintense on FLAIR sequence, with no significant contrast enhancement. MR spectroscopy detected increased colon and decreased NAA composition, and the maximum colon to NAA index was 1.8, suggestive of neoplasms. Diffusion tensor imaging cryptography was used to perform motor and language fiber tracking, revealing various eloquent subcortical fibers adjacent to the lesion. Functional MR revealed motor and language activation cortex. These process data were crucial for pre-surgical planning and exported to the intraoperative navigation system. The patient was placed supine with his head turned 45 degrees contralaterally and the neck slightly extended to facilitate good venous return. A bone flap was tailored according to the neuronavigation imaging. Tack-up sutures were placed around the edges of the bone window. The patient is then awakened and subsequently mapping is performed. Upon opening the dura, a six-contact strip electrode placed directly on the cortex was utilized to identify the central sulcus by polarity reversal of the median nerve SEPs. Stimulation was then performed over the entire exposed cortical surface, using a bipolar electrical stimulator probe to identify motor and language cortex. These positive sites were labeled and covered. Neuronavigation was used to precisely mark the boundaries of the lesion. The arachnoid was dissected and the sylvian veins were protected. In non-eloquent areas of the inferior frontal gyrus, fistulation of the cortex was performed to expose the insula. The neuronavigation system was implemented throughout the surgical procedure to not only help the surgeon determine the extent of tumor invasion, but also help identify important anatomical structures. CUSA was used to gradually resect the tumor beneath the frontal operculum. Throughout the resection, the patient was routinely tested for speech, sensory, and motor function, especially when resection was adjacent to the eloquent cortex or pathways. Tissue samples were sent for frozen section. The results suggested low-grade glioma. The temporal operculum was fistulated in a similar fashion for further resection of the insular lesion in zones 3 and 4, according to the Bird-Sinai classification. The MCA bifurcates at the Lyman insula, forming various M2 branches on the surface of the insula. Resection should be carried out in between these vessels, and the tissue selection parameter of CUSA was set above 3 for vascular protection. Positioned deep to the insular cortex are the extreme capsule, colostrum, putamen, the external capsule, and the internal capsule. Subcortical stimulation was performed to identify language pathways using a monopolar probe. The uncinate fasciculus, the inferior frontal occipital fasciculus, all course at the same depths under the inferior limiting sulcus. The lateral lenticular striate arteries, which supply the internal capsule, putamen, and globus pallidus, should be spared. Electrocoagulation should be avoided if possible. Continuous language and motor subcortical mapping for identification of the internal capsule and corticospinal tract during the resection of zone 4 tumors is very important. The temple horn was exposed. The resection cavities were rinsed repeatedly with warm saline until hemostasis was achieved. Then, surgical was injected into each cavity. Intraoperative MR suggested approximately 95% removal of the lesion, achieving the pre-surgical planning goals. The bone plaque was restored and routine closure was carried out. The histopathological diagnosis was astrocytoma grade 2. The molecular pathology revealed IDH1 mutant and MGMT promoter methylation. These results suggested that the patient has a relatively good prognosis and is chemosensitive. Therefore, no adjuvant radiotherapy or chemotherapy was necessary. The patient was stable at the 6-month follow-up, and the imaging evaluation results were satisfactory. The patient's cognitive function returned to the preoperative baseline level.
So let's move on to the clinical outcome and the complication. We studied 255 consecutive cases of insular glioma that underwent transcortical tumor resection in our division. And in total, 172 cases had an extent of tumor resection larger than 90%. In the low-grade glioma group, 93 cases had an extensive tumor resection larger than 90%. Residual tumor are mostly located in the putamen region, posterior insular point, as well as the superior parainsular region in more than half cases. Extent of tumor resection is an independent predictor for overall survival in both low-grade and high-grade cases. Patients with extent of tumor resection larger than 90% had longer survival among low-grade gliomas. For patients with gross total tumor resection had a better prognosis than those with subtotal resection among high-grade glioma cases. The post-operative permanent neurological deficit is only about 50% of 172 cases. The vascular infarction is the leading cause of disability after insular glioma surgery compared with direct injury of motor and language pathway. So in conclusion, we think the transcortical surgical approach can achieve maximal safe insular glioma resection. In addition, the incorporation of adjunct technologies such as multimodal brain imaging, as well as mapping of cortical and subcortical eloquent brain structure into transcortical approach favors post-operative neurological outcomes and prolongs patient survival. So that's all my talk. Thank you so much for your kind attention. Thank you.
Great thanks for Professor Dr. Wu for this detailed experience and detailed distinguished work. Thank you a lot for this. May we open discussion for 5 minutes from the panelists? Please, the panelists, for any questions to raise this question to Dr. Wu. Yes.
Well, yeah, I have a question to Dr. Wu about his technique in resecting the tumor. As I've seen, you're using most of the time the ultrasonic aspirator to take out the tumor. Wouldn't that cause any trauma to the surrounding elegant tissue in your surgery? Or do you find it very safe to use the ultrasonic aspirator?
You mean the transcortical?
Yes, in the transcortical approach, yeah.
Yeah, I think for eloquent side insular glioma resection, transcortical window should be, before make a transcortical window, we should perform awake brain mapping. We should spare the eloquent area. For example, for the Broca area, we should spare the pars opercularis and make a window in the pars triangularis, something like that. Of course, I understand for some vascular neurosurgeon or traditional neurosurgeon, they prefer to use to open the severe fissure. But to my opinion, transcortical approach is much safer. And the expose of the surgical corridor is much extensive than transcerebral fissure. So that's my opinion.
Yeah.
Thank you.
No, actually, my question about the use of the ultrasonic aspirator, the CUSA or
ultrasound. You mean CUSA? Oh yeah. Yeah. I prefer to use CUSA, especially for low-grade glioma. You know, for low-grade insular glioma, sometimes we need not do the hemostasis when we suck the tumor lesion if we use the CUSA. So that's why I prefer to use the CUSA. Thank you very much.
Thank you.
I think I would like to introduce Ahmad Morsi, Dr. Ahmad Morsi, Associate Professor in the Azia University, and he's specialized in functional neurosurgery. Ahmad, are you here?
Yes, Prof.
Do you want to make any comments about the talk of Professor Wu?
Thanks a lot for the nice meeting and nice talk. And I'm also preferring an insular gliomas transcortical surgery with awake surgery and brain mapping techniques. It's actually giving us more corridor and giving us more success in reaching extent of resection. So I'm also with the transcortical approach. It's very useful in insular gliomas, but you should use brain mapping techniques and awake techniques in such cases, especially in eloquent site. Thank you.
Thank you for your comment. Thank you.
Thank you. For the sake of time, I think now we proceed to our next speaker, Omar.
Yes, we would like to welcome Professor Mustafa Qutb to present his talk about the surgery of eloquent areas of brain. Yes, welcome, Prof.
Well, thank you very much for inviting me to this valuable meeting. And I would like to share my humble experience on operating in eloquent areas of the brain. The work I'm presenting here is based on some research we did in our department a few years ago. I hope you're seeing it now. It's about surgery of the eloquent areas of the brain, mainly for glioma surgery, as Professor Wu has told us. As you know, when you operate on eloquent areas of the brain, you have a conflict between radical resection of the tumor and the functional outcome of your patient. And this really represents a major conflict for us, has been always presenting a major conflict for us. Although we always speak about eloquent areas of the brain, but actually the brain is all functional. There is no area that is really silent. But we have agreed upon time that the areas concerning the motor functions, the sensory function, and the speech are the areas that are most eloquent. And these are represented by this foot-like area in the cortex, where it's surrounding the central sulcus and the sylvian fissure. In the last decade or so, the functional imaging of the brain has evolved to help us in identifying the eloquent areas and the functions of the brain. For the functional MRI, you know, it's mainly detects the local hemodynamic changes of the capillary and the draining veins during the process. It's helped us in preoperative diagnostic information of the anatomy, the pathology, and it's non-invasive like radiation with it's repeatable with delineation of the neuroplastic changes in the brain activity. For the motor and sensory paradigms, we mainly examine the paradigms for motor for the hand, foot, and tongue and lip. These are the main functions that are being examined during the study. And for the sensory paradigm, which is slightly less difficult to apply, you usually examine for ipsilateral finger opposition and touch sensations in the extremities. And these are examples of the functional MRI for the motor paradigm for the foot, hand, tongue, and showing the pyramidal tract in the MRI. For the other paradigm that's important is the language paradigm, mainly identifying the Broca's areas and the Wernicke's area to more or less in advance identify the areas concerned with speech in the patient, as in these images where we can see the Broca's areas, the Wernicke's area, and the associate speech areas in the functional MRI. It has the functional MRI has its limitation because it does not actually examine the function of the brain, but rather the hemodynamic changes, which are not direct neural activity. It needs a high level of cooperation and calmness of the patient. So in poorly cooperative patients, it cannot be done. It can be affected by the presence of a brain tumor that affects the motor function, and the tactile stimulation gives a weaker bold signal, especially for the lower limb. And for the language tasks, you need to have patient training and language ability. And of course, in brain shift, this affects your the location of the eloquent areas according to the shift of the brain. Another examination that is complementary to the functional MRI is the diffusion tensor imaging, which actually measures the movement of the water molecule in the tracts during the function. It provides information about deformation, displacement, and the interruption of the white matter tracts. It delineates the eloquent subcortical and cortical areas. Like in these images where you use diffusion tensor images to delineate the cortical tract with its deformation here. And this is the front occipital fascicle, the ansonate fascicle. And if you combine it with functional imaging and the same images, you have a more elaborate images of the brain and its function in relation to the lesion of the brain, like here. Another technique that we used for preserving the eloquent areas of the brain during surgery is the awake craniotomy. In the awake craniotomy, you have to you avoid the general anesthesia, or you just use it for short periods of times during surgery, either at the induction of surgery or sometimes during surgery, just to push the patient down. But most of the time, the patient is awake to help you to identify the eloquent areas and the functions of the brain. you have to do intraoperative mapping of functional brain regions, as Professor Wu have just shown us. It has a limitation that the patient shouldn't be in the extremities of age. It's not suitable for very young patients or very old patients. The patient should be cooperative, of sound mental functions, and the medical status of the patient is stable enough to have him or her for the period of surgery awake without. There's some anesthetic considerations. If you are going to use the alternating between general and local anesthesia, the anesthetist should be capable and able to move from both techniques at a very short periods. There are some intraoperative complications that are very hazardous, especially the seizures, the inadequate pain control, and vomiting or respiratory distress. In such cases, you might have to complete your surgery under general anesthesia, or even to abort the surgery altogether. In doing the awake craniotomy, you have to block the sensory nerves of the scalp before or after putting the patient to sleep. You can start by putting the patient to sleep under general anesthesia. You have to block the scalp nerves, open the scalp, the skull, and the dura, and then you awake the patient. Or you can start the patient all through awake, doing just the blocking of the nerves while the patient is awake with mild sedation, and you do the whole procedure. But then you'll have a problem of opening the dura, because the sensory supply of the dura does not come from the nerves that supply the face or the head. So you have to block the ophthalmic and the mandibular divisions of the trigeminal nerve, and sometimes you'll have to even block the C2 and C3 rami and the vagus nerve to achieve proper dural anesthesia. In this patient, in this videos, we'll show an operation that was done under this technique. As you can see here, the patient is reciting verses of the Quran. And he's communicating with the anesthetist and doing some motor functions. At the same time, this procedure of the surgery is done until total resection of the tumor. And at the end of surgery, you can see the patient. It's actually, these films and images were taken after full consent of the patient. We have operated upon 40-something patients using these techniques. We grouped them into 3 groups. In the group 1, we did both functional preoperative MRI and awake craniotomy. In the second group, we did only functional MRI and did the surgery under general anesthesia. And in group 3 or group C, we did only awake craniotomy without doing functional MRI preoperatively. As you can see in the 2 groups of awake craniotomy, when we did awake craniotomy either with or without doing functional MRI, the percentage of ladies that were operated upon were less than the percentage of males. And this is because of the compliance of the patient. We were more comfortable on operating on male patients in this situation. While when we did the surgery under general anesthesia, there was almost an equal number of patients in both groups. These are some examples of the images for our patients for group A. This is the functional MRI, and this is the post-operative image for this patient immediately post-operatively. Another patient for group A, and with functional MRI and post-operative, showing almost total resection of the tumor. The group B under general anesthesia, this is the tumor, and this is the functional MRI, and the patient was operated upon general anesthesia, and this is the resection of the tumor of the through a transcortical approach. This is another case for group B with functional MRI and post-operative imaging. For group C, another case, and this is post-operatively. We didn't do here functional imaging. Another case for group C with post-operative image. The result of our research showed that in cases where we did both functional MRI and awake craniotomy, the section, the percentage of total resection was higher than the other groups. However, when we did functional MRI only, we were able to do more resection than when we relied only on the functional, the awake craniotomy. The thing that was very important in the resection was the extent of tumor infiltration. When it is infiltrating, actually the infiltration was equal in percentage in both the groups where we did the functional MRI, and we knew about the infiltration beforehand. In cases of infiltration, we were not able to do total resection except in a small percentage of patients, while in cases where the tracts were displaced and functional areas were displaced, we were able to do total resection in almost all cases. In the cases where we did awake craniotomy only without functional MRI, we were not courage enough, and the patient function did not help us to do total resection. But most of the cases we did subtotal resection or debulking of the patient. This was caused by either development of neurological deficit intraoperatively or patient exhaustion in some cases. The complications were more or less similar in all the groups, except for a couple of cases of one case of mortality that was intraoperatively in group 1 for a patient who had intractable seizures during surgery. The most common complication was the new transient deficit and the transient worsened original deficit. But otherwise, the complications are more or less the same. For our outcome, when we use both awake craniotomy and functional MRI, or even functional MRI alone, we had more excellent results. However, when you rely only on functional MRI, you have a high percentage of fair results in comparison when you rely on both of the functional and the awake craniotomy. In awake craniotomy, you have more of an equal distribution of the results. In conclusion, although the extent of tumor resection using preoperative functional MRI compared to that of using awake craniotomy was relatively better, however, the continuous direct monitoring of the patient function during awake craniotomy improved the overall functional outcome. And the best results obtained by combining the two techniques, as you have seen. The functional neurological outcome following surgical resection of gliomas is intimately influenced by preoperative neurological deficit, the histopathology of the tumor, adoption of functional MRI, the diffusion test and imaging and awake craniotomy, the intraoperative operative neuronavigation, the functional cortical and subcortical stimulation techniques, and most importantly, the behavior of the tumor, whether infiltrating or displacing the surrounding neurological structures. Thank you very much for your kind invitation and for listening to my presentation. Thank you.
Thank you, Professor Mustafa Qod, for this nice talk with good experience in this field. May we open discussion for 5 minutes from the panelists? Do you have any comments?
Good afternoon, everybody.
Yes, welcome, Professor. Professor Osama Ghannami is Professor of Neurosurgery at Al-Azhar University and the former Dean of Al-Azhar University. Welcome, Professor Osama.
Well, I must say, every day I listen to the colleagues about the awake craniotomy, but get refrained to do it. You're taking. I'm sorry, I'm not doing that at all. But what I'm doing in glioma like that is I use the operating microscope. Then I can see clearly where is the tumor, and I choose the trajectory which really away from the functional part, whatever speech or leg or motor area. And the pictures and the scans and the images I've seen with my dear friend, Professor Qutb, I see that why should I do all that, although I can just jump and do it dashly, no problem in it? Why should I take long hours? Why should I subject the patient for such seizures during and awaking? He's awake and all this, and I could do it very quickly, and surgery doesn't need all these complicated techniques and hassles. In fact, the prognosis, would it make such, does it really deserve or necessitate such techniques or not? Thank you.
Well,
It's a very crucial questions. Please, we need the answer from the panelists. Please, Dr. Mustafa, please.
Well, of course, I congratulate Professor Osama on his superb knowledge of anatomy and surgical technique. However, I believe that to identify the important areas of the brain during surgery helps to minimize the bad outcome from surgery in areas that are really important. Of course, if Professor Osama can operate safely in these areas without using the techniques of functional MRI or awake craniotomy, this is very good, but I don't think this is really reproducible by many surgeons around the world.
And Dr. Wu, please, your comments on the Dr. Osama questions, please.
Yes, I think Dr. Ghandour, his work is very interesting and very, I think it's very essential, especially for eloquent glioma surgery. I believe awake craniotomy is the gold standard for brain mapping, especially for language and even for some cognitive evaluation during surgical procedure. And I have one small question for Dr. Ghandour. Will you use the laryngeal mask during awake anesthesia? Thank you.
Yeah, actually, that's what we're using. When we put the patient to sleep is by using a laryngeal mask, so that we can take it off easily when we want the patient to get up to communicate with us during surgery. Yeah, that's how. Thank you very much.
Dr. Ashraf Labed, your comment on the questions of the Professor Osama Ghannam, please.
Actually, as we all know, there are some tumor location where we don't prefer to intervene or interfere in these locations because of the risk of developing neurological deficit in the language or in the power, especially for those with diffuse lesions in the brain in eloquent areas. I wonder. I mean, it's sometimes actually we in the early years we prefer to conserve these patients and don't interfere, just worrying for about the inducing a neurological deficit. But with the help of this new technology, why don't we use it to get better results and much less risk for the patient? In fact, as we know, I mean, there are many patients we conserve in the past years without intervening, fearing of this problem. But now we have the equipments and we have the facility to interfere and to give better quality of life for the patient. So why don't we use it? This is my opinion, actually.
Thanks for all.
Just,
Yes, yes,
just
please.
forgive me, dear friends and professors. I mean, preoperatively, I know this patient has no problem with speech, so I would know exactly the anatomy. I would be far away from the superior temporal gyrus and far away from the posterior inferior part of the frontal gyrus. And also, if the patient has the problem of language, so I know it's already there. Also, I choose a part far away from this area, then I can take the tumor easily. And if I added the risk, he is already dysphasic preoperatively. And the same for the motor area. I go away and he sees the edema before the tumor or after the tumor. So they can locate, where should I go? Should I go from the front or from the back, from the medial aspect, as if I'm going transcallosal? I mean, I'm not objecting you. Probably you are smarter than me in doing that. But I don't feel to take such a long way and long techniques and such and eventually it's a glioma. Whatever you do, they come back even if they're grade 1. Thank you.
Well,
I think
may I have a comment here?
yes, please.
I don't know where did Professor Osama had the notion that it is longer than the usual surgery, because it usually takes the same time as if I do it, whether I do it as an awake patient or under general anesthesia. It takes almost the same time. There's no much time difference between the two surgeries. I don't think the time factor here is important. Actually, you have to work in a hurry when you are doing an awake surgery.
Well, sorry, the cases I've seen it with my friends and colleagues. Probably they were beginner. I
yes.
saw took long the whole day for a case of glioma. I just
you shouldn't take long time because the local anesthesia would wear off. Then you'll have a big problem.
I think it's a very good discussion between two schools. The school who use the microscope and depends on the original neuroanatomy, and between another school who adds the new techniques and advanced technology with brain mapping and awake craniotomy. I think this will still stay. This discussion will not end at all. And thanks for all the panelists and for the
Sorry,
sake of the time.
can I?
Omar, I think Ahmed Morsi would like to make a comment. Ahmed, go ahead,
Yes.
please.
Yes.
Thanks, Prof, and thanks for the nice presentation. I just want to make a very important conclusion that intraoperative brain mapping is very important in such cases. And intraoperative brain mapping is the only way to prevent a deficit which you want to do. And awake craniotomy is just a technique to perform intraoperative brain mapping. But awake craniotomy alone doesn't the main technique. The main technique is to use the intraoperative mapping techniques, like using neurophysiological monitoring in spinal tumors, using neurophysiological monitoring in scoliosis surgery. So intraoperative brain mapping is our tool, and awake craniotomy is just the technique to perform this mapping techniques. But getting the patient just awake without using any neurophysiological monitoring is not the point which we wanted to stress. Thank you.
Thank you, Dr. Morsi. For the sake of the time, may I call Professor Dr. Ashraf Lavyad, the Director of Functional Neurosurgery Unit in Angels University, to present his talk about the diffuse low-grade gliomas in eloquent areas, changing concepts in surgery. Yes, welcome.
Thank you, Professor El-Ghandour and Professor Omar Youssef for giving me this opportunity, and also thank you for the Utopia for organizing this webinar. My presentation is actually about the what we have discussed now about the concept of management of diffuse low-grade glioma in eloquent brain. Actually, this subject has gained increasing attention in recent years, both in the surgical indication and in the surgical technique. And I will also present some our early experience in dealing with this tumor entity. As well known, diffuse low-grade gliomas are very slowly growing tumors. They are infiltrative, although benign natured, and they tend to locate within eloquent brain. Usually manifest as only seizures in young or middle-aged adults who are usually fully functioning. This clinical scenario leads to conflicting decision between observation and intervention, fearing of the potential neurological deficit that might result from injury to this eloquent region during tumor resection. However, due to the significant advances in knowledge of the natural history and the biology of the disease, the increased use of preoperative neuroimaging modalities and intraoperative brain mapping techniques, the management paradigm of diffuse low-grade gliomas are evolving from watchful waiting to more aggressive interventional management. In fact, there is increasing interest in studying the behavior of these tumors, and many clinical studies have been published in recent years concerning the natural history and prognosis of these tumors. Mandone suggested that these tumors are progressive neoplastic lesion, and over 70% will transform to anaplastic tumors or glioblastoma within a decade. Palod suggested that these patients passes into 3 stages: the pre-symptomatic stage of unknown duration, as evidenced by many tumors discovered accidentally, symptomatic period of about 7 years after the initial presentation. Usually the patient presents just with epilepsy and might be controlled on treatment. And then the transformational stage of 2 to 3 years of more rapid tumor progression associated with induction of anaplesia. Most of the recent studies have favored early surgical intervention rather than conservative management. Palod et al. Documented that the growth rate of diffuse low-grade glioma is approximately 4 millimeters per year, and then eventually accelerating within months, leading to inevitable anaplastic transformation. This means that there is no static or stationary diffuse low-grade glioma. Giacola mentioned that patients with diffuse low-grade glioma undergoing early maximal safe resection have a survival advantage over those undergoing a biopsy or delayed resection. Of course, we know the poor prognostic factors in surgery for diffuse low-grade glioma include age over 40 years, if the patient developed neurological deficit, if the tumor is larger than 6 centimeter or crossing the midline. So if we operate on these patients before these bad prognostic features, the results will be much better. Dufault stated that even when located in eloquent region, diffuse low-grade glioma rarely present with neurological deficit. The slow tumor expansion allow a plastic reorganization of neural function, which is displaced away from the tumor to adjacent brain. In fact, the implication of this is that the tumor itself is non-functioning, and even looking inoperable lesion can be resected if the functional boundaries of the tumor are defined by brain PEM. So the therapeutic approach to diffuse low-grade glioma is undergoing a change to a more aggressive mode based on the data that the tumor will eventually show biological progression. But we have to put in mind that resection of these tumors cannot cure diffuse low-grade glioma. So minimizing the operative morbidity must be our priority during surgery. Nowadays, there are a large number of techniques that can be used preoperatively to define the eloquent cortical and areas and subcortical tracts, like functional MRI, DTI, and tractography. While intraoperative anatomical localization can be done using the neuronavigation, intraoperative ultrasound, and functional confirmation can be achieved by the electrophysiological brain mapping technique. As we see in functional MRI, thanks to neuroplasticity, you can see here the right-hand area in the normal location, the right-hand area, while here it has been pushed to use tumor here. But actually, the resection border cannot be identified if you are going to take this tumor out. You cannot identify the resection border between the tumor and this eloquent areas. So the intraoperative brain mapping technique is still considered the reference technique for identification of eloquent brain areas. This is the intraoperative monitoring system we use, where the subdermal needle electrodes are inserted in the corresponding muscles on the contralateral side. As you can see here, the facial muscles, biceps, quadriceps, femoris, and so on. These are the subdermal needle electrodes inserted in the corresponding muscles of interest. And we use the Ogeman bipolar probe for cortical and subcortical stimulation. I will not go through the details, as I understand that Professor Wu will kindly give us a full lecture about motor mapping soon. We have operated on 32 patients with diffuse low-grade glioma in eloquent area. Two-thirds of the patients were in the dominant hemisphere and one-third were in the non-dominant. About 70% of the patients presented with epilepsy, 4 patients presented with neurological deficit, and 6 patients presented with epilepsy and neurological deficit. Regarding anesthesia, for those patients who had perilulandic lesions, we used the total intravenous infusion anesthesia of propofol and fentanyl. Of course, volatile anesthetics are avoided. Neuromuscular blocking agents can be used only for intubation. For those who underwent asleep, awake approach for the lesions in the eloquent areas and the language area, of course, patient education is very important regarding the description of the procedure, the operating room environment, the noisy during craniotomy, the Mayfield fixation, the abnormal sensation during stimulation, and so on. We used neural navigation and end-optic monitoring, except in 4 patients here in because their motor power was less than grade 3, because actually motor mapping require normal or near normal motor power to be reliable. This for asleep approach, we use the Presdex infusion. And in addition to circumferential scalp incision and local infiltration of the skin flap itself, the patient should lie in comfortable position in the Mayfield. Better to be in the lateral decubitus, just to guard against aspiration if he vomited. And the surgical drape should not cover the patient head. Regarding our cases, the distance regarding the distance of the lesion from the eloquent area in the functional MRI, the eloquent cortex was 0 distance or displaced by the tumor in 70% of patients, while it was less than 1 centimeter in 30% of cases. The eloquent tracts were pushed or attenuated in about 90% of cases, while it was disrupted or infiltrated in 12% of cases. Most of the diffuse low-grade glioma actually push or attenuate the subcortical tracts rather than infiltrating the tracts as in high-grade tumors. We prefer wide craniotomy to avoid eloquent brain incarceration in analocraniotomy, and also to expose the cortical areas of interest for stimulation. And the borders of the resection is identified either by inspection or by the neural navigation and ultrasound as well. And also the functional area or eloquent areas are identified using the cortical stimulation. We use the sub-pale resection technique. After identification of the area of resection, the resection starts by cauterization of the cortical pia overlying the lesion, as we see. And the small pia vessels are coagulated, and the pia, this is the small pale vessels, and the pia here is divided either by sharp dissector or microscissor. Of course, respecting the adjacent eloquent cortex. After exposure of the whole surface of the resection area, one of the choices to resect the tumor is either to work on the tumor internally and debulk it toward the margin as a piecemeal, or to define the margin all around the tumor. I'll just start the video. In fact, as we can see, we have to define the margin all around the tumor before starting internal debulking, because actually if we begin to debulk internally extensively without defining the margin, then it will most probably end
جاي
in
تحت انزل.
persistent bleeding with loss of the
الو
brain
ايوه يا عمر.
interface and subtotal resection.
ناخد سؤالين كده ولا ايه؟ ولا ايه رايك؟ عشان ما يبقى زيه زيهم يعني. ولا ايه رايك؟ بس جهز له سؤال برضه ولا حاجه، ما انا مش ضامن هجيب اسئله منين. طيب عشان برضه يحس ان احنا اهتمينا بيه يعني. بس سؤالين بس وننقل بقى على الاخراني ده، وفي الاخر نعمل بانل ديسكشن كده 10 دقائق ولا حاجه. طيب يا عمور، مع السلامه. مع السلامه.
So the main aim actually is to work around the tumor and coagulate the pale vessels around the tumor, aiming to devascularize the tumor before starting internal debulking. This will result in less blood loss during removal of the tumor and more efficient hemostasis following tumor removal. This is the final stage after performing good devascularization of the tumor and performing internal debulking. Then it's easy to resect the tumor in a vascular field and to use either scissor or kuza or sucker to remove the tumor. Can you do that? I just put this video just to stress that we have to preserve the cortical veins while we are testing the tumor. We have operated in this gyrus and this gyrus, and we have to use large cortical veins. Ultrasound actually is very helpful in defining the individual tumor. And in each step, we have to again test for the eloquent area by electrocortical or subcortical stimulation. Just it's either you get some after discharge, as you see here in the monitor, or sometimes you get movement, vigorous movement from the patient limb itself. These are some cases we have operated upon. This is one of the earliest cases, about approaching 5 years now. This is a 33-year-old patient presented with left right focal fits of 3 years duration. Actually, it was intractable seizure and not responding to 3 medications. And he was a truck driver, and he, of course, he retired because of this illness. And as we can see here, the lesion is actually just anterior to the right-hand area and is pushing the corticospinal tract. I actually brought this patient just to say that when we started this technique, we prefer to operate on small lesions until we get more experience in operating these patients, either for us as a surgical team or for the anesthetic team as well. This is his early post-operative MRI, and this is his 2 years post-operative MRI showing nearly no evident tumor, and he hasn't received any adjuvant radiotherapy. In fact, this patient stopped the medication on his own 1 year post-operatively, and he is now about more than 3 years fit-free. This is a male patient, 48-year-old, presented with headache and mild dysphagia with generalized fits. As we see here, the left, this is the vernix area here, and this is the Broca's area. And actually, the left arcuate and uncinate fasciculi were attenuated by the tumor. This is the early post-operative MRI showing just a blood product within the tumor cavity. And this is the 9 months post-operative MRI without radiotherapy, and actually his fits controlled on medication immediately post-operative. This is an example of a patient who underwent awake craniotomy. As you can see, he's
منبه
about 15
تمام.
years old.
تمام.
And he was very cooperative during surgery.
محمود طبعا من بداية من يوم السبت.
So the age actually is not an impact while performing awake craniotomy.
ساعة نص بنت تليفون.
The last case, this is a 24-year-old presented with generalized seizure of 10-year duration, and recently okay. Okay. This is the last case showing a lesion here in the periorlandic area. The left hand area just anterior to the tumor, and the left foot area is just medial to the tumor. We used the somatosensory evoked potential with phase reversal technique to identify the central sulcus. And actually, this is the resection area, and this is the hand knob area. This is 2.5 year post-operative MRI without adjuvant therapy. Actually, the patient showed some improvement in her motor power, and her fits is controlled. So our results showed that we have achieved total resection in about 60% of our patients, and subtotal resection in 40% of cases. Of the 32 patients, 50% of them developed immediate postoperative deficit. For those who were intact preoperatively, 40% of them developed new deficit, while those who had preoperative deficit, 70% of them developed deterioration of their preoperative neurological deficit. However, after 1 month, the picture differed completely. Those patients who were intact preoperatively and had transient deficit, they regained their full intact neurological function after 1 month, while over the 10 patients who had preoperative deficit, At 1 month, 3 of them showed improvement in their preoperative deficit. 5 of them showed improvement after transient decline, while 2 of them regained to their preoperative status after transient decline. So there was no persistent deficit in any of our patients. As regards the seizure outcome, at 1 year postoperatively, preoperatively, actually, there were 40% of patients controlled on medication, and 60% their seizure were uncontrolled on medication. After 1 year, 80% of the patients were controlled on medication, and the other 6 patients showed some improvement in their seizure control. After 1 year, 10 of these 22 patients stopped treatment against medical advice. 10 still on medication, and 10 had and 2 had recurrence after stopping treatment. So, in conclusion, the integration of pre- and intraoperative anatomical and functional studies allow the functional tumor resection that significantly widen the extent of resection in diffuse low-grade glioma. Surgical treatment of diffuse low-grade glioma has been shown to prolong patient survival, reduce malignant transformation, and improve quality of life, as well as seizure control. The technique of subpale dissection makes identification of cortical anatomy easier, allowing a complete tumor resection with protection of normal brain surrounding the lesion. With subpale dissection, the small vessels supplying the lesion through the pia are easily identified, cauterized, and divided, so the tumor is devascularized before its removal, resulting in less blood loss during removal and more efficient hemostasis following resection. Thank you very much.
Thank you, Professor Asha, for this very excellent work and for your dedication to introduce these new advanced surgeries in our university. Thanks a lot for this interesting work. We have a question in the question answer icon, and after that we will open discussion for 5 minutes only. One question about the use of fluorescein. Do you have any experience for the use of fluorescein during your surgery?
The question for me?
Yes, Dr. Ashraf, yes.
Well, no, but as far as I know, fluorescein is helpful in high-grade tumors, not in low-grade tumors. So I think it might be helpful in glioblastomas or other malignant tumors. But in diffuse low-grade glioma, I don't think it is helpful. But anyway, I haven't used it.
Another question for you, again, in your experience, which has better outcome, gliomas near cortical eloquent areas or near eloquent tracts?
In fact, damage to the white matter tract has a higher possibility of inducing permanent damage rather than cortical injury. So we have to be very cautious while dealing with the subcortical tracts.
Any comments from the panel, please? Dr.
Thank you, Professor Ashraf. I'm Ahmed Morsi. Thanks for the nice presentation. Always a very wonderful work. Just my question is, how much percentage of intraoperative stimulation induced seizures? So we are using stimulation cortical and subcortical for those low grades, perirolandic. So the main complication intraoperative for awake patients especially is the intraoperative seizures. So in your series, how much this percentage of intraoperative seizures?
Actually, we have started to use the high frequency stimulation more commonly than before. And with high frequency stimulation, Terreno 5, we haven't met this problem. But earlier, when we used the low frequency stimulation, We had only one case who had intraoperative seizure, and we had to use the called the ringer lactate solution to stop it. In fact, I still use low frequency stimulation for language mapping, but for pre-Rolandic mapping, I use a high frequency stimulation.
And Dr. Wu, do you have any comment, please?
Yes, I think Dr. Ashraf's lecture is very exciting, and his work is talent. And to answer your question about epilepsy, in our division, I think the incidence of stimulation-induced epilepsy, the rate is about only 5%. So I think control the intensity and control the currency. The power of the currency is very important to decrease the incidence of epilepsy. And in case of seizure, I usually to use the iced ringer solution irrigation to control the epilepsy. Of course, epilepsy is a very dangerous complication during awake mapping. Thank you.
Thank you, Dr. Wu, for this comment. For the sake of time, could we shift to the last presentation from Professor Wu about the motor mapping, Ronalding, pre-Ronalding, and insular cortex? Yes, welcome, Professor.
Thank you so much, Chairman. So this is my, sorry. This is my second topic. So previously, Professor already give us their experience of awake brain mapping. In my opinion, I think awake brain mapping is very safe and convenient for eloquent tumor resection, especially for Rolandic, pre-Rolandic, and insular cortical glioma resection, no matter dominant or non-dominant. So this book, Brain Mapping Indications and the Techniques, was published this year. So the content of this course can refer to the chapter written by me in this book. The primary objectives of glioma surgery at present are maximal safe tumor resection to reduce the tumor cell burden and improving the response of adjuvant treatment. In our division, we studied more than 800 gliomas with or without intraoperative neurophysiological monitoring. Direct electrical brain stimulation was found to not only reduce the morbidity, but also expand the overall survival of our patients. This explains why awake brain mapping has become the gold standard of eloquent tumor resection, depending on individualized cortical and subcortical functional boundary. True maximal safe resection is aimed for to offer patients balanced oncological as well as functional benefits. So in this lecture, we will discuss 5 topics. The first is about applied brain anatomy. The second is about speech production process. And the third topic is about multimodality for preoperative motor and the language functional localization. The fourth topic is about the detail of intraoperative neurophysiological monitoring. And then finally, I want to describe the advantage and disadvantage of sleep and awake intraoperative mapping. So as I mentioned in my previous lecture, anatomy is the fundamental for surgery. The Rolandic cortex, so-called the central lobe, consists of the precentral and the postcentral gyroid. Primary motor cortex is the Brodmann area 4 that consists of most parts of precentral gyrus and the anterior part of paracentral lobule in the medial aspect of the frontal lobe. The pre-Rolandic cortex and the supplementary motor cortex comprise the secondary motor cortex. the insular cortex lies deep within the lateral silvial fissure and is covered by the insular operculum. I had mentioned the detail in the previous lecture. These slides show the circle, gyro, and the cranial key points in applied anatomy of Verlandic cortex. So audience, if you have the interest about detailed information of these key points, you can read the textbook of applied cranial and cerebral anatomy of Dr. Ribas from Brazil. This slide shows the classical model of left parasylvian fissure motor as well as language cortex. For example, the auditory cortex in the transverse temporal gyrus, as I said, the first one is named Hishogyrus. And the posterior part of the superior temporal gyrus named the Wernicke area, and the inferior frontal gyrus, posterior part of the inferior frontal gyrus named the Broca area. It is responsible for language production. And also the ventral part of the motor cortex. So let's move on to the second topic, the speech production process. So this slide is a little bit complicated. So I will explain the detail of word production process, also called LRM model. So this slide shows the whole word production process during picture naming. When this picture of goat is seen, the occipital lobe is the first to get activated by the visual information. Next, the visual word form area, also called fusiform gyrus, gets activated to complete the visual recognition of the image. After this, the anterior to middle part of the middle temporal gyrus gets activated to complete the conceptual preparation and the lemma retrieval process. The time window for conceptual preparation process is about 0 to 200 milliseconds, which is responsible for converting the visual information into the exact concept of goats. The time window for lemma retrieval process is about 200 milliseconds to 75 milliseconds, which is responsible for further transforming the concept into exact word of goat. Next, the posterior part of middle temporal gyrus and superior temporal gyrus get activated to complete phonological code retrieval process. This step takes approximately 275 to 390 milliseconds, during which the word goat is translated into the correct phoneme. Before the end of phonological code retrieval process, the broadcast area gets activated to complete the phonological encoding process. The steps takes approximately 355 to 455 milliseconds and is responsible for creating the syllable sound and the rhythm information. Before the end of phonological encoding process, the ventral premotor cortex gets activated to complete the phonetic encoding process. The time window for this stage is approximately 410 to 600 milliseconds. This step is responsible for sequencing syllables and the coordinate movement of articulator. So finally, ventral sensory motor cortex activates to control the movement of the articulators and complete articulation. So this small video animation describes the whole process of the word recognition and sound production.
Goat.
So totally the whole procedure will take about 6 milliseconds. The second topic is about multimodality. I think Dr. Mustafa had give us a lot of case of preoperative multimodality. So the neuropsychological assessment scales commonly used in our department, in our division, include Edinburgh Handness, Karnofsky Performance Score, Mini Mental State Examination, MMSE, and the Boston Naming Test, and also the Aphasia Battery Test in Chinese. All patients must undergo neuropsychological assessment before and after surgery, since a comprehensive understanding of all types of dominant and recessive neurological dysfunctions before surgery allows the surgeon to provide the individualized treatment. Predict possible post-operative deficit, develop post-operative rehabilitation program, and provide a baseline for continuous assessment of post-operative neurological function. Functional MRI is the most common functional neuroimaging technique. Considering the false positive and the false negative rates, more appropriate use of functional MRI includes preoperative surgical planning and rehearsal, screening for functional brain regions that need to be verified by intraoperative brain mapping, and also providing cortical motor and language network information, such as the primary motor area for patients unable to undergo awake craniotomy. Sometimes we can use the resting state functional MRI imaging. So this is an illustrative case. So on this 3D reconstructed cortex, you can identify the red dots indicate the language activation. It is very close to the superior margin of the tumor. So we can also delineate the hand movement activation in blue dots. So this is a very typical use. We can reconstruct this case by using the BrainLab workstation. TMS, transcranial magnet stimulation, TMS, is a newer non-invasive preoperative cortical function mapping technique that involves altering the action potential of cortical neuron through a time-varying magnetic field, and it combines with neuronavigation technology to accurately localize functional cortical area. For example, for this case, different colors, dots indicate different functional cortex. Diffusion tensor imaging, DTI. DTI is based on the anisotropic imaging of the diffusion of the water molecule in the white matter fibers. And the DTI can be used to reconstruction a 3D model of subcortical neural pathway. For example, on these slides, we can identify different white matter fiber. For example, the corpus callosum, the motor pathway, the cortical spinal tract. This is the first compartment, and the second compartment is very critical for the hand movement, and the third compartment for the mouth, for the tongue, for the jaw movement, and also for the language production in the dominant side. We can also identify different green fiber indicate the language pathway, the acute fasciculus, superior longitudinal fasciculus as well. And we can also identify the cingulum and the fornix, for example, and the temporal stem. Despite the utility of functional MRI and the DTI in localizing functional brain areas, a multimodal approach in comprising intraoperative neurophysiological monitoring is essential to ensure the accuracy and the reliability of intraoperative functional brain mapping. So intraoperative neurophysiological monitoring comprises 4 parts. SSEP, somatosensory evoked potential, to locate the central circus. MEP, motor evoked potentials, MEP, to monitor the motor pathway integrity. Direct cortical stimulation in combination with EMG recording to map the primary motor and language cortex, and the direct subcortical stimulation to delineate the subcortical motor and the language pathway. An important initial step in the sensory motor function mapping is identifying the central circus by SSEP phase reversal technique. A strip electrode is placed on the surface of the presumed central circus to record SSEP by stimulating the median nerve. Although it is possible to identify the central circus by analyzing anatomical landmark on neuroimaging, anatomical and neuropsychological discrepancy can result in large localization errors. Clinically, the latency and amplitude of compound muscle action potential, CMAP, can often used as monitoring indicator of MEP. Continuous transcortical MEPs are widely used for tumor surgery of Rolandic, pre-Rolandic, and insular to monitor the integrity of motor pathway to achieve maximal safe tumor resection while preserving the motor function. Intraoperative direct electrical stimulation for both cortical and subcortical mapping is currently the gold standard technology for functional brain mapping. EMG records are more sensitive than muscle contraction and are monitored to reduce the stimulation threshold and the risk of intraoperative epilepsy. Bipolar electrodes can be used for cortical and subcortical motor mapping and also can be used for subcortical language pathway mapping. Monopolar electrodes was used only to detect the motor pathway with high frequency stimulation in our division. To identify functional cortical area as well as the subcortical functional margin are marked with the sterile tag. For example, on this photo, you can see the tag H mean the hand movement, M mean the mouth movement, and the L indicate the language production, and the P indicate the pyramidal tract and the motor pathway. Finally, I want to take some time to discuss the advantage and the disadvantage of asleep and awake intraoperative mapping. Awake mapping allows for testing of more neurological functions such as language, sensory, visual, as well as spatial awareness that require patient to be awake. Awake mapping allows for lower stimulating current intensity compared to general anesthesia. So it can be used to reduce the risk of intraoperative seizure and improve the brain mapping accuracy. Awake mapping allows localizing functional auxiliary motor region in the supplementary motor area and the parietal cortex that can be tested when awake. And we believe awake mapping allows monitoring advanced cognitive functions such as attention, such as judgment, such as computational power, such as mental status. So this slide mainly shows the indications and the contraindications for awake anesthesia. Because children's brain language network is immature and plastic, so there is no need to perform awake brain stimulation. Other contraindications include unstable mental status. For example, the patient is very anxious. It is the contraindication for awake craniotomy. And also higher intracranial pressure, sleep apnea syndrome, a very difficult airway, morbid obesity, claustrophobia, those are all contraindications for awake craniotomy. These slides show the plan B for avoidance and the management of complications during awake brain stimulation. For example, how to control the seizure, how to manage the emergency airway. So how to decrease the evaluated intracranial pressure. And in case of vomiting, sometimes vomiting is very dangerous for our awake patient because I never use the laryngeal mask for our patient or awake patient. All awake patients are use supine position in our division, mainly due to two reasons. The first reason is my patients feel more comfortable in supine position. The second reason is intraoperative MI scan requirements, because all my glioma surgery was operated in intraoperative MI surgical suite. We will put a pillow under the shoulder, head rotated to the right side corresponding to different area during the operation. For example, 0 degree for superior frontal gyrus, cingulum gyrus, 30 degree for middle frontal, inferior frontal gyrus, as well as for mesotemporal limbic paralimbic system. And 45 degrees for limbic, for insular, for parasylvian fissure region, for ventral central lobe, for lateral and anterior temporal lobe. 60 degree for posterior temporal lobe, for temporal occipital region, for supramarginal gyrus, for angular gyrus, and also for parietal operculum. This slide shows the workflow of mapping protocols of awake surgery. We detected the positive motor response, negative motor response, as well as picture naming reaction in turn. So this is another video to show for better communication with awake cases and controlling the brain mapping process. We will use a brain mapping interactive stimulation system, so-called brain mist system, in our operating theater.
In neurosurgery, it's very important to protect key functional areas of the brain for our patients. Therefore, we have developed a preoperative and intraoperative system for localization and protection of brain functional areas. Before operation, the patient is first examined by functional magnetic resonance imaging by using the visual and audio stimulation system. While being scanned, patient is instructed to perform motor, language, and other tasks. Imaging data will be automatically processed to generate brain function map, which could be used as a reference for doctors in pre-surgical planning. The map will also be sent to the surgical navigation system, guiding our surgeon to carry out operation precisely. If the patient is able to cooperate during the awake procedure, we can also use cortical electrical stimulation technology to locate the brain functional areas more accurately, which requires the use of the brain mapping interactive stimulation system we developed. This system integrates many functions, such as intraoperative task presentation, electrophysiological monitoring, muscle activity recording, etc., which is easy for members of the surgical team to cooperate with each other. According to the needs of different parts of the brain, the system has built-in menus of various tasks, which can guide patients to complete the corresponding tasks in the operation, such as counting, picture naming, retelling, hand and foot movements, etc. While implementing electrical stimulation, doctors can monitor the performance of the patients in real time through the system in order to avoid the critical functional cortex of patients. The above preoperative and intraoperation systems can help neurosurgeons to locate the functional brain area more accurately and quickly. As this typical case showed, with the help of the brain function localization and protection system, the surgeon can completely remove the brain tumor. To ensure that while removing brain tumor, the important brain function are not damaged, so that the patient can recover as soon as possible. Both of the two systems have been granted the registration certificate for medical device and are promoted nationwide, benefiting more patients.
So finally, I want to give you some example for the reaction during brain mapping. For example, these are positive cortical mapping results. For example, lip movement. And the tongue movement. And the hand motor. Sometimes we will record the negative cortical reaction. For example, this is a hand mode arrest. So the hand mode arrest causes the fist to stop. And the turn movement arrest. We believe speech arrest is also a kind of negative cortical mapping reaction. And anomia.
这张图片是
So in summary, we believe the critical location and the need of maximal safe resection of cerebral glioma, especially in the dominant hemisphere, Rolandic, pre-Rolandic, or insular, pose a significant risk of irreversible post-operative motor and language functional deficit. From our experience in glioma surgery, awake brain mapping combined with a multimodal image guided surgery offers best functional outcome in neuro-oncological surgery. Thank you so much for your attention.
Thanks a lot, Professor Wu, for this excellent work and excellent presentation. I think it will raise a lot of questions from the panelists. Please, anyone in the panelist, would you like to raise any questions, please? Dr. Ashraf, please, yes.
Thank you, Professor Yu, for this wonderful presentation. Actually, not uncommonly, when I'm operating on the perirolandic area and under total intravenous anesthesia, I get a response from the tongue response. What do you think about it? I mean, because the tongue actually is bilaterally represented, how much risky to operate while you in areas you get some response from the tongue under total intravenous anesthesia, not under awake anesthesia?
You mean the premotor area?
No, actually in the motor area, in the tongue area.
Yeah.
I get response. The neurophysiologist tell me that I get a tongue response.
Yes.
How risky to operate on this area?
Yes, I think it's a very good question. So for motor area, for the prerolandic cortex, the motor area, sometimes we can total resection the tumor without motor deficit. For example, the lesion located in the ventral part of a motor cortex. That means the motor cortex for the tongue, for the jaw, for the language production. So at that area, I believe the tumor can grow total resected without the deficit, the hand and the leg and the trunk movement. So we can still resect the tumor gross totally.
Yeah, I agree. Thank you.
Thank you.
And Dr. Faiz Obaid from Jordan, are you here?
Yes.
Yes, Dr. Faiz, would you like to share with us the Jordan experience or your experience in this field of surgery?
Thank you very much, Dr. Omar. Thank you, Dr. Ghandour. Thank you for all the speakers. Question and concern actually for Professor Hu. When we're operating in insular tumor, especially the dominant side, all the time we are worried about the Broca area and especially the vascular supply. During dissection, sometimes if you put retractors, especially there is an artery called the fronto-opercular artery, very easy to be affected and get deficit post-op. I need the advice about this technique to avoid injury or retraction over retraction. Is he rely on monitoring or cortical stimulation alone, or if there is any special device or advices to avoid injury to this vascular supply to the opercular area? Thank you.
Thank you. Thank you for your comment. So I totally agree with you. The blood supply, the vascular, is much more important than the cortical itself.
Yes, what's your advice, Dr. Wu? He asked for your advice for.
Yeah, well, I try to first do dissection. I'm adopting Professor Yazerjil technique. I used to split the Sylvian fissure and operating in the insula after splitting the Sylvian fissure. So Sylvian fissure splitting maybe give me more visualization to the blood supply. I can see the middle cerebral artery, the upper trunk, lower trunk, and I can see the blood supply to the opercula more easy than we call direct transcortical. I don't know what's his opinion.
So I totally understand you, because my mentor, Professor Zhou, he is a vascular neurosurgeon. He preferred to open the Sylvian fissure, but for me, I prefer to use transcortical approach, because I believe transcortical approach without any retraction, and you can got a better visual for the whole insula. So I prefer to use transcortical approach, no retraction. No retraction.
Yes, Dr. Wu, how do you preserve the vascular supply for the opercle and for the insula when you go through the transcortical?
You mean the lenticular-striate artery?
Yeah, all the perforates and all the vascular supply, how do you preserve it during the transcortical surgery?
So to my opinion, I prefer to use CUSA. I think CUSA is very useful especially for low-grade glioma resection. During tumor resection, the CUSA will never damage the cerebral artery branches, especially for the very thin wall of the lenticular-striate artery. CUSA is very promising tool for glioma surgery, I believe.
That means you depend on the CUSA from the start of the operation, or you start with the microscopic dissection, then shift to the CUSA? Which of them you start with them?
After doing a cortical window, we use the CUSA instead of the bipolar. I understand for some neurosurgeons, they prefer to use suction and the bipolar coagulation and the suction, coagulation and the suction. But for me, I prefer to use the CUSA instead of the bipolar and the suction.
Dr. Mustafa Qod, what's your experience and comment for these differences in the techniques?
Well, I fully agree with Professor Wu that to prevent vascular injury, the extensive use of the CUSA is very helpful because you can dissect the tumor from very thin vessels without actually injuring them. It's definitely a very useful tool to use. And I fully agree with Professor Yu. It's I've shifted some years ago to the transcortical approach to tumors around at the insula, rather than opening the insula and doing my surgery from the. So I fully agree with what he's doing.
And Dr. Ashraf, what do you prefer to preserve the vasculature? To open the Sabian fissure from outside and go to inside, or to start with the CUSA?
Transportical incision as well. Transportical approach actually is much easier, and actually you don't fiddle about the vessel, just go transcortical, and I think it's quite safe. So I prefer to do this. I actually have a question to Professor Hu.
Yes, please.
If after resection of the cortical part of the tumor, when do you start doing subcortical stimulation? I mean, at the bottom of the sulcus, or where, and how often you do that?
Yeah. So for motor mapping, I prefer to use a monopolar high frequency stimulation. For language subcortical mapping, I prefer to use the bipolar electrode for the language pathway mapping. And how often? So for motor mapping, sometimes I prefer to use continuous transcortical MEP instead of the frequent subcortical mapping. It's very convenient. So one of my technicians just record the EMG, and I just do the tumor resection by using the CUSA, by piecemeal technique. So if there is any decrease of the latency of the amplitude of EMG, my technician will notify me, and I will perform the subcortical motor mapping instead of the continuous MEP recording.
So you keep strip electrode over the motor area all the time, and you just do motor evoked potential every now and then.
Yes, yes, yes. Okay. And also the anatomy is essential for surgery. Sometimes we always keep in mind the anatomy.
There is a question for Dr. Wu. Dr. Abdul Bari asked, do you use the neurophysiologist to interpret this awake craniotomy, or you depend on yourself?
I use what?
Do you depend on the neurophysiology colleague, or you depend on the neurosurgery to interpret the awake craniotomy and mapping?
You mean the neurophysiology monitoring?
Yes, he asked you about the neurophysiological monitoring.
Okay.
It's done by you, by the neurophysiology colleague.
All right. So maybe the question is about how often to use the intraoperative neurophysiological monitoring.
No. He asked who do this job. Is the neurophysiologist colleague or the neurosurgeon?
Yeah. Dr. Helmi, he visits our operating theater frequently, so he knows the detail. One of my technicians, a male technician, he is responsible for the whole procedure of the monitoring.
And the interpretation with the technician or by the neurophysiologist?
Just the technician. Just the
technician also.
Yes. Yes.
And Dr. Ashraf and Dr. Mustafa, do you depend on a neurophysiologist or yourself, or which team?
I rely on your neurophysiologist, of course.
I have a neurophysiologist who works with me. Yes.
And Ahmed Morsi.
Again, your clinical sense has to be, has to have a role in interpreting what the neurophysiologist tells you. So you don't just rely on what he said.
And Ahmed Morsi,
Dr. Omar, we rely on neurophysiologists. We have a very efficient neurophysiologist from Al-Asr Al-Aini, and he is very efficient actually. And yes, and he is very nice in interpreting electrocorticography also, because I'm doing electrocorticography recently. I'm doing electrocorticography in all our cases which are presenting with seizures. So I'm doing electrocorticography, which needs a neurophysiologist to interpret intraoperative.
Great. Dr. Nasser.
I think after this very important discussion, we come to the end of this webinar, and it's time to close this webinar. It was very successful webinar. I would like to thank our distinguished speakers, Professor Jin Song Yu, Professor Mustafa Qutb, Professor Ashraf Al-Abyad, Professor Omar Youssef. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time and experience. Thank you for supporting neurosurgery in Egypt and Africa. Let me just make an announcement. Next Friday, webinar number 24 is going to be about neurotraumatology. We have another 3 distinguished speakers. Professor Tariq Khan is chairman of the Neurotraumatology Committee in the World Federation of Neurosurgical Societies, Professor Abdelhafiz Shihabuddin, and Professor Ahmed El-Fiqi. Thanks to all attendees. Thanks to the organizing committee. Thanks to all of you, and hope to see you all again in another occasion. Thank you.
Thank you. Thank you, Doctor.
Have a good night.
You.